to pull out of that exhibit hall. It's just like, oh my God, like moths to a flame, I think. So congratulations to those of you that have extracted yourself for a few minutes from the exhibit hall to come back into the main stage for what I'm certain is going to be an outstanding end to what has been an amazing, just amazing energy in here, the excitement, the content, the hallway discussions. Just really thrilled. I wish I could be everywhere at once and talk to all of you at once. I've been really enjoying this event, so thank you all again for contributing. So first up today is my colleague and friend, Dr. Brian Lacy, who is an esteemed professor of medicine and gastroenterology at the Mayo Clinic in Jacksonville. He's really a world-renowned expert in gastroenterology, and in particular in disorders of gut-brain interaction, which we now call DGBIs. Anyone that takes care of people in a behavioral health clinic and in mental health capacity knows that the brain and the gut are indeed connected. Abdominal pain, bloating, irritable bowel syndrome, dyspepsia, these are very, very common conditions that often overlap with psychological comorbidities. And so Dr. Lacy is an expert in these conditions and also has been exploring and now publishing data using virtual reality to manage some of these conditions. And he's going to today share with us a background, for starters, about what are these DGBIs, because not everyone here is a gastroenterologist, and why would we use VR. And then later, I think this is going to really set up one of our next talks, which also is about GI, but other conditions as well. So we'll get there, but first, Dr. Lacy, I'd like to invite you to the stage. Thank you so much for being with us today, all the way from Florida. You're mic'd up now.
Wow, so thank you so much. This is wonderful. What an amazing day, so very excited to be here, and Brendan has really given my introduction here. So I've kind of set this discussion up into two different parts. One is to a little bit set the stage because we have a number of providers from different countries and with different backgrounds and interests, and then to really focus on how VR may help some of these conditions. Because some of you are getting CME credit, it's nice to know our objectives, and what I really want to talk about is what these disorders of gut-brain interaction are, how they develop, and realize how complex they are, and whether they may be amenable to treatments that fail standard therapy, such as VR now. And so let me just describe for you a couple of patients I saw in the last month or so. 37-year-old woman with early satiety and epigastric pain. She fills up very quickly after a meal. That persists for months after a stomach flu. A 24-year-old man with 7 years of near daily abdominal pain and diarrhea. Another young woman with daily abdominal pain that prevents her from working. She couldn't finish college. A very thin 22-year-old man with reflux symptoms and significant chest pain despite medical therapy and a normal pH test showing he doesn't have acid reflux. And a 50-year-old woman with persistent abdominal pain after developing both COVID and food poisoning about the same time, bad luck, who now also has some anxiety. And the question is, what's in common here? What kind of links them? Well, all these patients have disorders of gut-brain interaction. And these DGBIs, disorders of gut-brain interaction, are what we used to call functional bowel disorders. And that's really what I focus on. Neuromuscular disorders of the GI tract, what we also call motility disorders, and functional bowel disorders. And functional bowel disorders, it's a good term because the GI tract may look normal. You do blood tests, they're all normal. You do x-rays, they're all normal. You do endoscopies, they're all normal. But the GI tract really doesn't function very well. But some clinicians thought that was pejorative, but also in the last 10 years, we've learned so much more about the brain-gut connection. And so when we think about DGBIs, this is really dysfunction between the brain-gut, this brain-gut axis, and of course between the gut and the brain. And when we think about these disorders, a predominant symptom is that of abdominal pain. And so this is really a pain central or pain predominant disorder. So how do we define these disorders? Well, we use symptoms. So this is a symptom-based diagnosis because, as I mentioned, your endoscopy may be normal, all your blood work is normal, your CAT scans are normal, but you're struggling with daily symptoms of pain and fullness and pressure and discomfort. We use the Rome 4 criteria, and the Rome 4 criteria are designed for both clinical use and for research projects. So if you're going to do research in the field, we want you to use the Rome 4 criteria. which are pretty easy. Basically, symptoms should have started about 6 months ago, and they should be present in the last 3 months. And then, as I've mentioned, basically any test you can imagine is normal, and we do not have a biomarker yet for these diseases, so we can't check a blood sample and say you have IBS or you have functional dyspepsia. The key concept here is that of abdominal pain. And so for you non-clinicians, I just want to mention a little bit, when I think about this, there are 3 key things we should know. The concept of allodynia, and this is when I examine somebody and I barely touch their abdomen and they say this is excruciating pain. We heard a personal story from Dr. Spiegel this morning after a bad infection. Wearing a shirt should not cause significant chest pain. That's this concept of allodynia. All these patients have a disorder of visceral hypersensitivity. They are more sensitive than normal, and this is this concept of hyperalgesia, where that threshold is moved from the left to the right. So that firm pressure may cause pain, but light pressure should not cause extreme pain. That's hyperalgesia, and of course, many of these people are hypervigilant. And as I explain this to my patients in the office, what I tell them is you have a wiring problem in the GI tract, right? There you have an electrical wiring problem. Remember, you have more nerves in the GI tract than you do in the spinal cord, 5 times as many, 500 million versus 100 million. And most of those nerves are sensory in nature, and so these people are really wired differently. So how common are these problems? And the answer is they're incredibly common. So if you surveyed nearly 73,000 people across 33 countries, what you'd realize is that about 30 to 40% of the world's population has a DGBI, disorder of gut-brain interaction. And some of these include functional dyspepsia and IBS, chronic constipation. What's the natural history of these disorders? Well, they can be incredibly bothersome. They're intrusive. They cause daily symptoms. They're oftentimes refractory to therapy. We know that for many patients, these are chronic in nature, and we talk about 50% of patients with functional dyspepsia having persistent symptoms. We know that there are a lot of misconceptions, so many patients with IBS are greatly concerned their symptoms will turn into inflammatory bowel disease, Crohn's disease, or ulcerative colitis. About 30% believe that our IBS symptoms will increase their risk for colorectal cancer. All untrue, of course. We know that many patients with functional dyspepsia, the pain, the pressure, the fullness, the meal-related symptoms are worried this will increase their risk for stomach cancer or ulcer disease. Again, not true. Fortunately, these disorders do not change mortality or lifespan, but significantly impact patients' quality of life. So why do these disorders develop? So when I think about this, I like to think about the 3 Ps. We talk about predisposing factors, we talk about precipitating factors, and perpetuating factors. So we think about predisposing factors, we recognize that for many DGBIs, IBS and functional dyspepsia as examples, there likely is a genetic predisposition, and that about 25 to 30% of patients may have the correct genes that enable them later in life to develop IBS or functional dyspepsia. Not a guarantee, but a predisposing factor. But usually it has to occur in other circumstances as well, and I call these insults. So patients may have a genetic predisposition, but then there are early childhood experiences that are adverse, emotional trauma, physical trauma, sexual trauma, parents becoming divorced. Maybe there's an infection early in life, multiple courses of antibiotics. And then as childhood progresses to adolescence or adulthood, maybe there are other stressors. There's a COVID infection, there's a food poisoning infection, there's a tubal ligation, minor surgery, and all this then kind of overwhelms the GI tract, and you develop these IBS symptoms or functional dyspepsia or chronic abdominal pain. Those are the patients in the community. Those who come to tertiary care centers oftentimes have these perpetuating factors of significant ongoing anxiety, depression, catastrophization, somatization, hopelessness, and poor coping skills. So what's the impact of all this? Huge impact, a dramatic impact in patients' quality of life on par with moderate depression. And we spend about $20 billion a year in both direct and indirect costs treating IBS symptoms, and nearly the same amount for treating symptoms of functional dyspepsia. So how do you treat these conditions then? So this is the first couple things are, patients use a lot of over-the-counter agents, but generally they're ineffective. And of course, those patients, if it was effective, would never be seen a healthcare provider. So that's a minority of patients who get benefit. Peppermint oil might be a good example, helpful in some patients, but generally doesn't treat these global symptoms. If we use IBS as an example, fortunately, we now have 8 FDA-approved medications for the treatment of IBS. 5 for IBS with constipation, 3 for IBS with diarrhea. And those are pretty good medicines at treating gut symptoms, but they're really not good at treating this brain-gut disorder. So patients may say, yes, my constipation or diarrhea is better, but I still have pain, and of course it hasn't helped their anxiety or depression. We oftentimes use neuromodulators, and these are the tricyclic antidepressants and the SNRIs, serotonin, norepinephrine reuptake inhibitors, or atypical agents such as mirtazapine or Remeron. But many patients feel there's a stigma attached to them because they think, oh, you just think I'm depressed or I'm just anxious. I want my gut pain treated. But many of these patients also suffer side effects from these medications, or they become so fatigued they can't work, as an example. Hypnotherapy and CBT, cognitive behavioral therapy, are great treatment regimens because they do treat this gut-brain axis, and there's lots of good data to support their use. But think about all the roadblocks involved. You can't find the right provider. It's very labor intensive. You may have to go to the office. It's expensive, and your insurance company doesn't pay for it. So that really opens the field for VR. So let's think about whether or not VR may be the right treatment regimen for many of these DGBIs. So let's go back and think about what these DGBIs are, right? So we're thinking about all of these factors: stress, depression, catastrophization, emotional insults that can affect the brain, and then of course that can affect the gut, sending these downstream signals to the GI tract. And we know that those downstream signals can change neuromuscular function in the GI tract, can even change the gut microbiome, as an example. Similarly, changes in gut function cycle back and can change the brain. And it leads to this concept of central sensitization, right? That the brain becomes much more sensitive. And so, as I explain to my patients with chronic pain from either IBS or functional dyspepsia or other reasons, your brain is just super sensitive. What you're feeling now, other people may have, but they don't feel it. My analogy is, as I get older, as my daughter always reminds me, I have to turn the radio up a little bit more to hear the radio, right? These patients turn the radio on and it's going full blast. Their brain is being bombarded all the time with these signals from their gut. It's disruptive. And so the question is, could we use VR to act on the brain and then break down or block some of these signals to the GI tract? Well, let's take a look. So let's think about IBS first. And IBS is a great example because depending on which definition you use, we may have up to 10 to 15% of the US population affected with these symptoms of abdominal pain and disordered bowel habits, oftentimes refractory to OTC agents or prescription medications. And we know that many of these patients have ongoing psychological distress as well. So we saw this diagram this morning. So this is this incredibly powerful and innovative pilot study from Brendan Spiegel and colleagues here at Cedars-Sinai, where patients with IBS, there are about 15 patients from the local area, about 75% were women, 10 years of IBS symptoms, and that's important to understand. These are patients with ongoing symptoms, refractory to other therapy, who were enrolled in this program and were interviewed, and the interviews were recorded and analyzed, and they kept going through these interviews and kept going through the data and the responses to reformulate and revise their interactive VR program. And I think there are about 23 or 24 separate edits to that program. And then with these patients, when they were enrolled in this program, and you saw that lobby this morning, could go to the exam room and learn about IBS and learn about the brain-gut axis. And then they could be sent to the theater of the mind where they learn this CBT, this IBS-directed cognitive behavioral therapy to improve their symptoms. They could then at different times go to the chill room and learn about IBS-directed meditation to help their symptoms. You saw this screenshot this morning about the zoom-out room where we talked about IBS and how it stigmatizes patients and leads to social isolation. If they're having a really bad day, they could have a flare of their IBS. As an example, they could go to the urgent care center and learn some new training. They could check on their skills. And of course, you talked about the trophy room, kind of encouraging them about how they've been doing and what they could learn better. This is not one-stop shopping. So as Dr. Spiegel mentioned this morning, you don't do a 15-minute VR program and your IBS is cured, because we don't have a cure for IBS. We don't have a cure for diabetes or thyroid disease either, right? But this looks, if you know cognitive behavioral therapy, this looks very similar to a lot of cognitive behavioral therapy programs, because that's what a lot of this is, right? We're working on this brain-gut axis, and we're teaching new tools and new treatment strategies. And you can see that during this 8-week program, they're going to these rooms at different times, or learning new skills, learning new techniques to master their skills. And you saw that screenshot from this morning, where for patients with IBS, one of their concerns is you're in the middle of a meeting, you have this sudden urge, I've got to run to the bathroom, and you're afraid you won't be able to get to the bathroom because somebody else is in the bathroom, or you're running to the bathroom, and now there are 13 people in line waiting to use the bathroom, and they can teach you skill sets on how to deal with that. Really informative and impressive. And the question is, was this helpful to those patients in this pilot study? Absolutely, and more will come. So this is published as really a cutting-edge article in the American Journal of Gastroenterology, really probably the best clinical journal for GI doctors in North America. And as Dr. Spiegel mentioned this morning, if you took that screenshot and the QR code, this information will be available, and the techniques will be available to other researchers. What about functional dyspepsia? So I've kind of mentioned functional dyspepsia, those symptoms of fullness and pressure and discomfort, oftentimes meal-related symptoms, oftentimes with nausea. I sit down to eat a meal, I'm hungry, but I can only take a few bites because I'm overly stuffed. As I mentioned, blood work is normal. You do an endoscopy, it's completely normal. Your ultrasound and CAT scan may be normal as well. No medication is approved for this. There's no FDA-approved medications. Clinicians frequently use a proton pump inhibitor, omeprazole, pantoprazole, et cetera, but that only works in about 1 in 10 to 1 in 11 people. Could virtual reality improve this chronic pain disorder? So we studied this as a pilot study. So this is with Dr. David Kangemi at Mayo Clinic Rochester and Brennan Spiegel and myself. We enrolled 45 patients, which is actually a large number of patients for functional dyspepsia trial. They were randomized in a 2-to-1 pairing to either this immersive 3D dimensional VR program or more of a 2D nature program. So they all had the exact same headsets, were given the same instructions, used it for about the same period of time each day. This was a pilot study and basically self-funded, so it was pretty limited during this 2-week study. We used validated questionnaires, something called the Nepean Dyspepsia Index from Australia, Nick Talley, and the PAGI-SIM Patient Assessment GI Quality of Life Symptoms, and we followed these patients over 2 weeks. What did we find? So this is from one of the abstracts we presented. The manuscript's being written, should be submitted next month for publication. What we found is during this 2-week period, which seems very short, but impactful because the average year of symptoms for these patients was nearly 4 years, patients noted a significant improvement in overall global functional dyspepsia scores, had an improvement in symptoms of heartburn and regurgitation, but also pain. So we're very encouraged by these preliminary data, and fortunately, Dr. Kangemi won a NICE award from the American College of Gastroenterology, and we now will be going to a larger, longer study to verify these results. So what were the final diagnoses of our patients? This first woman had functional dyspepsia, post-infection functional dyspepsia, which developed after a stomach flu. The second patient had IBS with diarrhea, which can occur in men, by the way, not just women. This third person had centrally mediated abdominal pain syndrome, daily abdominal pain that disrupts life. The next patient had reflux hypersensitivity and functional chest pain, non-cardiac chest pain, and the last patient had post-infection IBS. So all of these disorders, that we link them as disorders of gut-brain interaction, they are all coming under the rubric of these DGBIs. They're all characterized by chronic abdominal pain. And I would suggest to the group that all of these would be amenable to treatment with virtual reality, which I think by this immersion process, by distraction, and through all the other techniques of how VR works, it should help therapy. So I would encourage others in the room here and those who are interested in research and DGBIs that VR therapy would be a wonderful tool, and I think we're going to learn more about that in about 2 lectures from Dr. Wen. Thank you very much, and Brennan, we're right on track.